We are excited to have doctors from various specialties talk about their experience, and we hope that the information being shared here today will help lead to better and improved outcomes for patients in the United States and abroad.
Good afternoon and good morning, everyone. I welcome you all to this webinar. I am Dr. Beck from Assam Medical Center. It is my great honor to moderate the Thyroid RFA population session in this webinar. We invite the 4 speakers from United States. They will introduce very interesting cases today.
My first case, a 50-year-old woman who presented with neck fullness, some trouble clearing her throat, and voice hoarseness. And she is Los Angeles. She's an actress, she's a singer, and this was interfering with her work. From her initial evaluation, this is her ultrasound examination. And what we can see is a multicentric, predominantly solid thyroid nodule.
So approaching, we typically approach in the transsystemic approach, as Dr. Beck was speaking about. Here we're coming in medial to lateral to avoid that danger triangle and to stay well away from the recurrent laryngeal nerve. Here you can see our probe as deep into the nodule. You can see the tip is at the posterior lateral margin, and we start our ablation from that point. Follow-up, so like I said, ours is a newish program. Our follow-up is really only 1 month at this point.
So I'm not going to go into details, but basically this is an 84-year-old gentleman who is been maxed on methimazole by his endocrinologist, and his TSH continued to be undetectable. So 84, multiple medical problems, including atrial fibrillation, and not candidate for surgery, no interest in surgery. So he was referred to me for possibly considering the radiofrequency ablation, showing that the efficacy of this. I was asked to maybe discuss 5 questions, but and basically always people ask if this should be done in the office or in the operating room. So I honestly believe that this can be done in the office. However, I mean, I do them as an outpatient, obviously, but in US, we have to follow certain guidelines with our hospitals. So I was asked to do this in the OR because...
This is post-RFA, the nodule. This is about 6 months later. The nodule measures 30 by 20 by 24 at this point, and had reduced in size to 7.2 milliliters, which was a change of almost 60% in 6 months. And you can also see the change in the appearance of the nodule, where the pre-ablation ultrasound shows the nodule was heterogeneous, more hypoechoic, and very solid. I think you can appreciate in the ultrasound cine clip on the right side of the screen that the nodule is now more hypoechoic, more heterogeneous, and is demonstrating evidence of undergoing degeneration. So the questions for Dr. Beck and the panel is, do you agree that radiofrequency ablation in this nodule would be reasonable? First of all, based on the cytology, its enlargement over time, and its appearance.
The audience asked about the more aggressive pain control method, even deep cervical plexus block. I agree. In our experience, the primary parathyroid adenoma is much easier than treat secondary hyperparathyroidism, and intrathyroidal parathyroid is easier than outside one. So it's time to close our interesting session. So thank you for your very nice introduction of your cases, and thank you for a lot of questions from the audience. Thank you so much.
Again, thank you. Bye-bye.
Thank you. See you.